Michael Lee, and I think I'm not going to do a whole lot of introduction because he definitely is somebody that we all know a lot or have seen around quite a bit, and most of you know. But he is a second-generation physician at Orthopedics Northeast, and I think that that's one of the things that I'd like to impress upon you about Ortho Northeast is that we are a 52-year-old, 53-year-old company, pushing 54-year-old company, and with hundreds of employees, jobs that are stable here in the, and in the region. And I just think that that's important. I mean, there's a lot of good medical practice been around just as long. I'm not trying to separate us from some of the other great employers in town, but this is something that, we should be proud of, to have a legacy company that your kids want to work in afterwards. So I'll turn it over to the kid.
Is the mic on? Can you hear me okay?
Yeah.
Am I the last speaker of the day?
Yeah.
Okay, good. Good news, the weather's real nice, as you probably know. This will be a shorter talk than scheduled also, and I think we're ahead of time. I've actually been here 20 years now. I started practice in 1994. I did general orthopedics training, and then I did a year fellowship in sports medicine. So my concentration is mainly knee and shoulder. So over the years, I did knee replacements when I came, and as a lot of us in sports medicine, we tend to do more knee replacements as time goes on, as our patients age, surgeons don't age, as we get more experience, I guess. Some of them develop arthritis, but that practice tends to grow as we go on. So I'd like to talk to you about a topic that is probably something you are not aware of. There are a lot of orthopedic surgeons that are not aware of this topic. And it's controversial at minimum. It's somewhat radical in some people's minds. And hopefully I can explain that to you and get a better insight on what I think is a different and better way of doing a knee replacement. Now, work comp injuries don't often result in knee replacements, but I have had several patients over the years that have had knee replacements through work comp. So, as potential patients, this may be of interest to you. With your healthcare background, friends or family may ask you about knee replacements. So hopefully this will give you some insight into what I think is going to be a really popular technique as time goes on. So when we talk about knee replacements, we talk about knee arthroplasty, and traditionally we call it total knee arthroplasty. The technique I want to refer to is called anatomic total knee arthroplasty. And that's in distinction of traditional knee replacement, which I will show you is not anatomic. So the traditional technique for all knee replacements, when we put the parts in, we don't just randomly cut the bone and put the parts on and size it and say that's good to go. It's a bit more precise than you might think. When we put our cutting jigs on to resect the bones. Now what we do basically, the way I explain to patients, is we resurface or cap the end of the bone. And we actually remove a minimum amount of bone to put the metal parts on. So we don't just whack out a bunch of bone above and below the knee and put a big chunk of metal in. It's fairly precisely milled in the way we take it off and the way we measure the angles. But the goal for decades, back from the 80s, is if you look at the x-ray on here from the hip to the knee to the ankle, we want that to be a straight line. And we call that the mechanical axis. And if that straight line from the center of the hip goes through the center of the knee, and we measure that, we want that angle to be 0. So that's the traditional goal. So the thought was, just like the tires on your car, the straighter the knee is, the better the parts may wear, because there's a plastic liner between the two metals. It's called polyethylene. And that plastic liner can wear over time. And if the knee is not aligned properly, we thought, well, it may wear more on the inside and more on the outside. So the thought was, the straighter you get the knee, the better. One of the problems is a straight knee doesn't mean a patient is going to load that knee in a straight fashion. A lot of patients have hip problems or scoliosis or flat feet or muscular imbalances that it's been shown with gait studies that even if the knee is straight, that doesn't mean that patient will load that knee in the middle. So the goal is good, but in reality, it doesn't mean that knee is going to be balanced, so to speak. So one concept I'll show to you here, we talk about varus and valgus in the knee. And varus mainly refers to whether the knee is bowed, and valgus is whether you're not kneed. So when we talk about the bone cuts on the tibia or the bone cuts on the femur, we tilt them one way or the other, and if it tilts one way, it's varus. And I'll show you, this is an x-ray of a patient that had both by knee, one with the traditional technique and one with the anatomic technique. And the traditional recommendation is to make or put the tibial component, the top of the tray here, perpendicular to the long axis of the leg. So this, I guess the other screen, sorry if you can't see it. What we want to do, if you draw a line from the center of the tray down to the center of the ankle, that angle should be 0 or 90 degrees, one or the other. So traditionally, you don't want to tilt that at all. It was thought that if you tilted that, that could result in uneven loading of the knee or result in loosening of the metal part as it's fixed to the bone. So traditionally, what you don't want to do is tilt it, which I've intentionally done here. That's tilted 3 degrees. So our goal always has been to get that tibial component perpendicular plus or minus 3 degrees. So one of the big differences with this technique is we feel it's okay to vary from that angle. So this is, since it tilts down toward the medial side, we call that varus. So I'll use the term varus. And I'll show you the traditional mechanical alignment for probably 95% of people changes the natural anatomy of that patient's knee. And not only the natural anatomy, but it also reflects what we call the kinematics of the knee. If you change the angle of the joint line, if you change the height of the joint line, or you rotate the parts, the mechanics of that knee are going to be different. So the problem with knee replacements is a good-looking x-ray doesn't mean the patient's going to do well. And we've seen that over and over again in the studies. We've seen it clinically. So many patients have a perfect-looking x-ray, but may be stiff, they may hurt, or they just say that it doesn't feel right to them. And I'll go over some studies here in a minute. 20%, up to 20% of patients are not satisfied with their knee replacement with the traditional technique. Now, that doesn't mean they're not better. A lot of patients have improvement in their pain. A lot of patients are still better than they were, but in the box where they say they're satisfied or not satisfied, it's up to 20%, and that's a big number. And I'll show you how big just in the U.S. and what the financial implications are. As I said, a straight knee may be stiff or painful. The problem we feel that is a well-aligned knee in the traditional sense. It may look straight on x-ray, but that may not be aligned to the way that patient's knee has functioned for decades. So there is a CT, or many studies, in fact the CT study showed that 98% of normal knees aren't perfectly straight to begin with. So are we using the wrong goal? Are we trying to put people straight when they shouldn't be straight, when they never were straight to begin with? So these are some studies just in the last, 3 of them in the last 4 years and one from 2007. These are major orthopedic journals. JBJS is our main journal. AAOS is our National Academy meeting where there are 20,000 surgeons attend that. CORE is clinical orthopedics. So they show, in fact, I talked to one of the industry reps from Warsaw, in their internal number of dissatisfaction on some of the studies they've done is 27%. So these are major institutions. These are major medical centers. They're not small community-based orthopedic studies. So in 2009 in the U.S. alone, there were 620,000 total knee replacements done. That's primary total knees, not redos, not revisions, but primary total knees. And in 2015, it's estimated there'll be 1 million primary knees next year. So if you think that 1 out of 5 is dissatisfied, that's 200,000 total knee replacements where these patients are not happy. they may be happy, but they're not completely satisfied. I don't want to mislabel that. And if you conservatively estimate that each knee around the country, the prices vary. In fact, in New York City, you may pay over $100,000 per knee. But if you conservatively estimate that each one is $50,000, in next year alone, that may be $1 billion of healthcare dollars spent on dissatisfied outcomes. So when surgeons that do replacements hear about this, they say, well, I understand that may be the case, but not that many of my patients are not happy. Well, there's a bias that I like to bring up, and surgeons don't like to hear this, including me, but it's called the illusory superiority effect. It's also known as the above average effect. So most drivers and most surgeons think their results are better than average. Well, the studies have been done in Europe and studies have been done in the US where over 80% of drivers, when asked what their driving acumen is, they say they're above average, and that is not possible. So this is my response to the surgeon that says, I don't have those poor results. So we talked about that cut on the tibia with regard to the 90-degree angle, or what we call a 0-degree cut. And I looked into the basis for that. And it started in the 1980s based off instruments, implants, and studies from the 1970s. The problem with those instruments and implants don't resemble anything of what we implant or use today. So some of those studies were based off implants that are totally foreign to how we're doing things now. There's a Mayo Clinic is one of the most well-known joint replacement centers in the world, and they probably have the highest volume of any center in the country. The Mayo Clinic arthroplasty book from the 1990s cited 3 studies on the recommendation to put the tibia cut at 0 degrees. So this is one of the implants that was from the 70s. It's called the spherocentric knee. Now, apologize if you're not familiar with how modern knees look, but this doesn't look anything like modern knees. There are a medial runner, a lateral runner, and then there's a post with a ball in the middle. It's like a hip and a knee combined. So this implant didn't do very well, but this is one of the studies that was referenced as not to put the knee in anything but a 0-degree cut. The second study involved what's called the geometric knee, which doesn't resemble anything like we use today either. It has plastic here, around condyle here, and it did not address the patellofemoral joint. So this is not what we would call a total knee, but this involved resection of the bone much more than we would do now. The final one was what's called the polycentric knee, which is basically another rudimentary design. It's a metal runner in a plastic trough. These two are separate. You put one on the medial side, one on the lateral side. So those were the studies, 3 studies, the only 3 studies out of that book chapter talking about alignment for the tibia. The problem with the tibial cut not making it anatomic or making it custom to whatever the patient's individual angle is, if we put everybody at 0 degrees, it has unintended consequences when we align the femur, and I'll go over this with you. So the femoral bone cut is altered because we can't cut the tibia, or we don't cut the tibia anatomically. So we cut the tibia abnormally, and we're forced to do something different on the femur. The other effect is the recommendation was to make as little cut on the femurs, on the tibia as possible. So the problem is if you make the tibia cut too small, you can't get the parts in, and you have to cut more femur, and it raises the whole joint line, as we say. So there are several studies are showing that tilting that tibia actually is now, we feel, acceptable in many cases. And in many studies, there's several out of Europe that showing not only is it acceptable, but it's probably better for those patients whose natural alignment is already in that direction. So there's an article out of the Mayo Clinic from 2010. They looked at 400 knees with average follow-up of about 15 years. And basically, they concluded that the previous thoughts we had with regard to alignment and how long these knees are going to last probably has no bearing on their longevity. And in fact, the patients that were within that plus or minus 3 degrees of alignment had a higher revision rate than the patients that were out of the plus or minus 3 degree revision, or the plus or minus 3 degree alignment recommendation. So this was a landmark article really questioning our thoughts on alignment goals and should we be looking at alternatives. We'll skip through some of these articles. Another article out of Europe just from 2013, 143 knees, 7-year follow-up. The knees that were slightly invarus or slightly bowed did better clinically. They had higher, what we call Oxford scores, and higher knee society scores functionally. They had better motion and less pain. Another study out of Europe showed the same thing. So if we can align the tibia more anatomically, how we were made, then it will allow us to anatomically align the femur as well. So the goal with this technique is to anatomically align the components and anatomically or restore the patient's normal anatomy the way they were before they developed arthritis. So this gets a little technical, but it's pertinent to what we do technically, so I want to walk you through this. So there's a physician in Colorado who had a CT study back in 2005. And basically, he's the one that showed that 98% of knees aren't normally straight. We knew that was a high number, but he quantified it better. And what he concluded, and what others have concluded since, is that the shape of the femur really determines what we call the kinematics, or really the biomechanics of the knee and knee replacements. That is, if you alter the femur, no matter how you do it, one way, whether you tilt it or you rotate it, if you alter the femur, you have a high chance of altering the kinematics of that knee. So if you don't put it in anatomically, they may not have normal kinematics, basically. Dr. Pagnano is one of he's the chairman of orthopedics at the Mayo Clinic. He gave a talk in Japan last year, and one of his talks was the future of knee replacement arthroplasty. And in fact, we do a nearly identical procedure. He quoted in his talk that the 3-dimensional position of the femoral component is the prime driver of better function as knee replacement technology advances in the future. So we're coming to the conclusion that everything is based on getting the femur just right as far as the position of the component and rotation of the component. So Eckhoff, going back to the physician from Colorado, showed that the diameter of the part of the femur that articulates with the tibia. So this is a lateral view here of the femur, and this is posterior, this is anterior. So if you imagine the tibia down here, and the tibia flexes and extends, the part that touches the femur actually is a symmetric cylinder, both medially and laterally. If you look at a femur, at the end of the femur, it looks wildly asymmetric from one side to the other, but the part that forms the joint actually is quite symmetrical. So he proposed that what we call the axis, or if you imagine the axis is simply a hinge point. If you have the tibia down here, flexing and extending around the femur, what is the axis that rotates about? And he proposed that the axis is this cylinder axis, which bisects those symmetric cylinders. You can see how different it is from what we call the epicondylar axis. The epicondyles are the bumps on the bone where the collateral ligaments attach. The significance of the epicondylar axis is that's the axis or the hinge point to which we've aligned the total knees for decades. So if you believe Eckhoff's data in his CT information, you should be aligning it here, but we've been aligning the components to here, and you can see how divergent those are. So if you look up the femur, instead of looking on the front there, if you remove the tibia and look up the femur here, that's how we're looking here. So this would be posterior, and this would be the front of the femur. And you can again see how divergent those are. And the point here is the distance between this line, or this axis, the hinge point, in the back of the femur on one side, is the same distance over here. So it's actually quite symmetric when you consider the part that rotates with the tibia. Here are just a couple of oblique views showing again how divergent those axes are. We'll skip this part. So everybody has different anatomy, but the angle of the end of the femur in the population is 7 degrees. That is, this angle, if you connect the bottom of the femur, the femoral condyles, this tilts in that direction 7 degrees. Now, some people are 5 degrees, some people are 9 degrees. By convention, the traditional alignment technique puts everybody at 5 degrees. Now, that goes back again to the way these have been done for quite a while, but the initial cut, the initial recommendation is 2 degrees off the population average. And if an individual patient's angle is 9 degrees, you're going to be immediately 4 degrees off what your normal alignment is just with the very first thing we do. So again, I mentioned when we put on the metal parts, we take off the minimum amount of bone to get the parts on. Now the metal on the end of a typical replacement is 9 millimeters thick. So it makes sense that if you want to put on a 9 millimeter piece of metal, you want to take 9 millimeters off. You don't want to take off more than that, you don't want to take off less than that. But in reality, the traditional technique takes more than that on one side and less than that on the other side. So I'll walk you through what I mean by that. So if this is the patient's end of the joint, and we want to replace 9 millimeters of metal with, or replace the bone and cartilage with metal, it makes sense we want to take 9. So if we were going to put this on anatomically, you'd take the same amount off both sides. So if the patient has a 7 degree angle, we set our guide. Now the first guide we use is actually a rod that goes up the femur, and then a block comes up here and we set that at whatever angle. So I would set it at 7 degrees. The convention is setting it 5. But if you did the traditional mechanical approach and you set that at 5 degrees, instead of 7 degrees, what will happen? So what happens is your cutting block touches here, but since it's 5 degrees, it doesn't touch on that side. So then what you're going to do is you're going to take the right amount of bone here, but you're going to take too little bone here. Well, the problem is these knees have cartilage loss. So when we put the block up, it's not against cartilage, it's against bone. And there's 2 to 3 millimeters of cartilage loss when there's exposed bone. So if you put that 5 degree block up here and ignore the cartilage loss, what's going to happen? Well, what will happen is the block will touch the bone here, it will touch the cartilage here. So now you've resected the proper amount on the lateral side, but you've over-resected the medial side by 2 millimeters. A lot of these knees don't get fully straight before surgery, or what we call a flexion contracture, or they lack extension. So a very, very common way of overcoming that in surgery is to take more bone. So if somebody is lacking extension, what we commonly do is take 2 more millimeters of bone to try to get the knee straight. So what happens when you do that? Well, everything moves up 2 more millimeters. And what do you do then? Well, what ends up is you take 11 millimeters off the lateral side, which is 2 more than you wanted, if you want to replace it anatomically. And then you take 13 millimeters off the good side, or the other side, which is 4 more millimeters than you wanted. So what's happened is, this is what I mean by the mechanical technique does not anatomically replace the knee. With the very first cut we made on the bone in surgery, and we make probably 10 cuts, the very first cut, we've tilted that joint line 2 degrees, we've raised the joint line 4 millimeters on that side, and raised the joint line 2 millimeters on that side. Once that's done, there's no going back. So the very first cut in the majority of knee replacements malaligns the knee to some degree. Now, if a patient had a 5-degree angle here, if the normal alignment was 5 degrees instead of 7, you'd be pretty close, but you'd still have over-resected if you didn't account for the cartilage loss. Traditional technique ignores the cartilage loss. You just put it right up against the bone. So if you look at what we call that axial view, again, this is looking up the femur as if you're looking up my knee here. Again, we have these axes. Now, the amount of metal we put on to replace the back of the knee here can be 8 or 9 millimeters. So I'll walk you through the same concept here. So if we're replacing, on this will say 8 millimeters, but if we want to replace 8 millimeters, same concept here. So, however, the convention is not to resect equally on the posterior femur, but we rotate this guide 3 degrees externally. So that goes back to recommendations made because we don't cut the tibia anatomically. If we don't cut the tibia anatomically, you need to rotate the femoral component that way or externally. So we'll walk you through that again. So if this is a 0-degree rotation, you take the equal amounts of bone on both sides. But since by convention we actually rotated 3 degrees, we're going to take too much here and the right amount there. So let's walk through that. So if we do that, in the knee, 1 millimeter approximates 1 degree. So if we actually rotated 3 degrees, on this side we've taken 11 millimeters instead of 8. And we've taken the proper amount laterally. Well, the problem is, like a lot of these knees, they have cartilage loss. So if you have 2 millimeters of cartilage loss, you're okay. Oh. We'll keep going. So if you have 2 millimeters of cartilage loss here, what's going to happen? Well, that guide, when you put the guide up against the back here, if there's no cartilage there, it's going to be moved up 2 more millimeters. So when in fact you rotate that femoral component 5 degrees instead of 3 degrees, when in fact anatomic should be 0. So what does that result? So we've taken 3 more millimeters of bone here than we would have if we had, 5 more millimeters of bone here than we would have if we had just cut it anatomically. So the problem with these first 2 cuts we make, it malaligns what TF is tibiofemoral and FE is flexion extension. So we malalign those axes or those hinge points with the very first cuts we make, both in what we call the coronal plane and then the axial plane. So the traditional alignment, like I said, is not anatomic. And once these bone cuts are made, you can't go back and reference them. The way we do it anatomically, we make these cuts, we try to make everything equal, and we measure these bone cuts to the 1/2 millimeter. If there's more than a 1/2 millimeter of difference from one side to the other, we'll compensate and alter the cut or shim it, as we say. We've got these little washers or spacers. Well, we'll try to compensate when we do the next step. So just to give you some background, there's a gentleman in California that started this technique in 2006. Just a brilliant guy. He's a friend of mine, and I call him a scientist that does orthopedic surgery. But he really came up with this whole technique. And I found out about this. He was started in 2006. I found out about it in 2009, and I knew about it. I read about it, thought about it quite a bit. But it is such a different concept than what we're used to doing. It's very difficult to transition into trying this. So in 2000, I knew about it. 3 years later, in 2012, this article came out in one of our journals. And this is what really prompted me to go ahead and take the next step to start doing it. It's a gentleman from Gene Dossett from Arizona. He did a double-blinded randomized control study. What he did was take 41 patients and did what we call the anatomic, or Dr. Howell calls it kinematic alignment. And he took 41 patients with the same implant, same brand, same technique, same incision, except he did them mechanically, the way we would traditionally do it. So it's one surgeon doing 2 different techniques with the same implant. And he has no financial connection to the companies or any of the companies involved. So what did they find? Well, what they found, KA is kinematic, which is our anatomic technique. They had better satisfaction when they measured this patient satisfaction. There are different ways you can do that. There are surveys called the Oxford score, the Womack score, or the Knee Society score. In every measured parameter, they had better satisfaction, better function, and better motion. When we measure the outcome, what do they look like? The mechanical alignment goal is to get them 0. The ultimate alignment, when we do these patients kinematically or anatomically, comes out almost identical anyway. So we're getting pretty much to the same position, but we're more anatomically aligning these components. So their follow-up was 6 months in this study. It has subsequently been updated just earlier this year, and the results actually are slightly better, even more so in favor of the kinematically aligned patient. So when I first gave a version of this talk, it was about 1.5 years ago, and so I was about just over 1 year into starting this technique. I looked at my first 40 knees doing a new component. It was one of the new models on the Warsaw. So I wanted to do it with, because I can use different brands. We'll get some patients that request one brand or another. So I wanted to do 40 straight for X amount consecutively of the same brand, just so I could get a good feel of how these patients were doing. So we had 40 patients, 33 knees, and a minimum 6-month follow-up. Cruciate retaining means we keep the ligament called the posterior cruciate ligament. So what we find, and I'll walk you through the slide here. So MA means the mechanical axis. That's the line we draw from the hip through the knees to the ankles. So the mechanical axis preoperatively on these people was 2.1 degrees. That means on average they were bowed 2.1 degrees. And postoperatively they were 0.2 degrees. That's 0.2 of 1 degree off of being perfectly straight. So again, our goal wasn't to get them perfectly straight, but the technique basically gets them there anyway. The femoral valgus is that tilt I showed you just a little bit ago. Preoperatively, they were 7.4 degrees, 7.3, and then post-op 7.4. So we're able to reproduce that angle of the femur nearly identically. We're within 1/10 of a degree. The tibia varus, again, that tilt we talked about, we went from preoperatively 3 degrees to postoperatively 2 degrees. And then the slope, that is when you look on the side of the tibia, how much it tilts to the back. We were less than a degree off from what they were preoperatively. Oxford score, it's a real simple, easy survey that we have patients do. It's a 12-question survey. It's been validated in the U.S. It's from actually England. The Oxford score preoperatively is 17. Postoperatively, it's 42. The highest score you can get is 48. If I would fill out the Oxford score and I have no arthritis, I don't have knee problems, I would get a 47. Because if you have any trouble kneeling, you don't get a perfect score. The average total knee replacement in most studies shows an Oxford score of 35. So my first 40 that I followed for 6 months had this at 42. Dr. Dossett's study out of Arizona, his Oxford score was 42 as well. And Dr. Howell, his 3-year study shows an Oxford score of 42. So we just all happen to hit the same number. So we're 7 points above the average for a mechanically aligned or traditionally aligned replacement. Well, we should say about length of stay. Our length of stay is going down dramatically. We were 2.6 days, but this included 4 patients that had bilateral knees, a couple of whom stayed 4 or 5 days. So traditional, when I first started residency in the 80s, patients stayed 10 days for a knee replacement. And basically what we found is they're going to stay as long as you tell them they're going to stay. As I finished my residency, one of the guys said, well, I'm going to tell patients they're going to be there 5 days, and they started saying 5 days. So I used to tell them 3 days, now I tell them 2 days. And they're doing well enough that they can get out safely in 2 days for the most part. So let me just walk you through this case. I use this lady because when I was doing the talk, this lady came in that week. So I had done her other knee, the one that has the metal on it, previously, mechanically aligned knee. She was quite happy with that. Happy enough, she came back for her other knee. So again, it says 5 degrees valgus. That's what we set the guide at. Now, when we set the guide there and check x-rays, there are about 10% of people that are off what we wanted as far as mechanically aligning them. So the guides aren't perfect, we're not perfect, but she was right where we wanted to be. So on the femur, we were at 5 degrees, and the tibia, we were at 0 degrees. But look at her natural alignment here. She's 7 degrees of valgus on her other side and 3 degrees of varus on the tibia, which is the population average. But you can see how knock-kneed she is, and she's ground down the bone here on the tibia. So how do we do? Well, here's her post-op x-ray on the left side. We accurately reproduced. She's 7 degrees of valgus here, 3 degrees of varus here, just what she was preoperatively on that side. So this was the x-ray I showed you before. She was 3 degrees of varus here, and when you look at the long leg x-ray, it goes down to the center of the ankle. We're 3 degrees. Now this is off 90. It says 93, but it's 3 degrees off the 90 basically. So we're 3 degrees tilt here. We reproduce her anatomically. We're neutral there. And that looks perfect if that's your goal. This looks just what I wanted to because I set my goal differently. So when we draw the mechanical axis, she's right down the middle there. She's just slightly off the middle there. She's probably 1 degree off to the side, which is perfectly acceptable. The other thing is, as I talked about earlier, when we make those abnormal cuts on the femur, we change the level of the joint line. So since I measured my bone cuts to the 0.5 millimeter, I can be pretty sure that when we put that femoral component on, it's going to be about the same level that her native joint line was. So if you draw a line across the end of the femur here, that's where the metal meets the plastic. So that's her joint line. So since I know I'm within a 0.5 millimeter of her joint line here, if you compare her joint line on the other side, you can see how elevated that is. And with our digital x-ray, we can measure that. So her joint line is 4 millimeters higher than she is on this side, just like that calculation I showed earlier. Look at the tilt here. This is her tilt anatomically. This is her tilt on the other side. So we've changed the angle of her joint line and we've raised the angle of her joint line. Oh. So overall, what have I found? I've done probably 300 of these now since I started doing it. These patients, no question, have less pain and they have less swelling. One thing I did mention is with the mechanical alignment, since these knees are not being put in anatomically, when we put in our trial parts, we size things. We put in different sizes, we put in different thicknesses of the plastic. And when we don't put them in anatomically, that is, if we put them in mechanically, a lot of these knees are tight on one side or the other. They're not well balanced. So the way to get those balanced is you start cutting or releasing the ligaments. And the mechanical technique requires ligament releases probably 95% of the time. With this technique, since things are anatomically aligned, I do ligament releases probably 5% of the time. Not cutting the ligaments or detaching from the bone reduces pain and it reduces swelling, it reduces blood loss. So these patients get their motion back quicker, their therapy is a lot easier. Probably the biggest referral group I've had, my knee replacement practice has doubled in the last 2.5 years because of this. And the number one referrer I have are physical therapists. The therapists are seeing the difference. And I've had a lot of patients, I've had therapists call me spontaneously saying, what are you doing differently? Because the therapists are seeing a dramatic difference as well. MIS is minimally invasive surgery. You may have heard about minimally invasive knee replacement surgery, which was popular 10 to 12 years ago. What it was making a smaller skin incision, thinking that there would be less pain and a faster recovery. The problem is the pain isn't from the length of the incision. Patients didn't have less pain with that. And in fact, it was a detrimental technique in the fact that with a smaller incision, a lot of components ended up being malaligned. The surgeons couldn't see as well, and things weren't aligned properly. So there's actually a higher revision rate with the minimally invasive surgery. But the goals of the minimally invasive surgery were to reduce pain, increase the recovery, and decrease the morbidity. And basically, I think with this technique, we're accomplishing the minimally invasive surgery goals without the risks of the minimally invasive surgery. I think these knees are more quiet. As I said, they have less blood loss. We've done a couple of things to reduce blood loss in surgery over the last couple of years. The transfusion rate historically is between 5 and 10%. Now our transfusion criteria have diminished too, but I haven't transfused a patient in 2.5 years since I started this technique. One of the consequences is we've seen more thigh pain after this surgery. And I couldn't figure that out for the first few months. But what I figured out was we use a tourniquet during these surgeries. And if the tourniquet is high enough, it's like a blood pressure cuff on for an hour. You know, blood pressure cuff's not comfortable. And these patients have an anesthetic. But when they wake up, they can get tourniquet pain, which is their thigh pain. The reason patients started complaining of thigh pain is they had less knee pain. The thigh pain was worse than their knee pain. And I am being totally honest, I had never heard that complaint prior to doing this technique. The other thing I changed in therapy, I eliminated passive range of motion. A lot of patients will say the worst experience about a knee replacement is when the therapist pushes on the knee to try to get more bend. So those knees are painful, they're stiff, and they're very swollen. And when the therapist pushes on it, that makes everything worse. What I found was these patients were getting their motion and their flexion back without the passive motion. And in fact, what I've concluded is that passive motion may be actually counterproductive. Because when you take a stiff, sore, painful knee and make it more stiff and painful and swollen with passive motion, it's going to make the motion worse in some cases. So I've completely eliminated the passive motion. So the therapist, unfortunately, by virtue of their training, they just can't help themselves. They want to push like crazy on those knees. And I'll get calls saying, "Are you really sure you don't want us to push on it?" So that's been a real patient satisfier. They really like, the ones that have had it before and have it now without the passive motion, they really like that difference. So since the 1980s, the success of knee replacement arthroplasty has not changed much. The materials, the metals have changed, the plastic has changed, but unfortunately the outcomes have not changed. And those of us that are doing this alignment think it's because the alignment goal may be not the proper goal with mechanical alignment. Computer-assisted surgery, which can align these components during surgery very precisely, it's been very clear that the computer-assisted surgery more accurately aligns the knees. But they've all been done with mechanical alignment. The studies are very clear that they show improved accuracy of alignment, but the clinical outcome has not improved whatsoever. So I have a saying, I make fun of the computer guys, that I say that they more accurately malalign the knee with that technique, but it has not improved outcomes. So can we do better? If we're doing 1 million knees next year and 200,000, I'm very happy. We should be doing better than that. So where do we go from here? Well, the orthopedic companies are very, very interested in this. Unfortunately, because the FDA doesn't acknowledge this, I can do it. However, I can put a knee in backwards, and the FDA can't tell me to do otherwise. There'll be ramifications of that. I don't do that. But the companies, because the FDA does not recognize this yet, cannot promote it. So they can't have surgeons come in to learn it. They can't talk about it at meetings, whatever. So we're somewhat limited there, but there is significant interest growing. We have some short-term studies, but the midterm studies are pending. And the limits aren't yet defined. How much can you tilt it one way or the other? So I've had patients over the years say, "Doc, I'm trying to wait until the next great thing. I want to wait for that big breakthrough in total knees." And that's been from day one since I've been in practice. And when patients say that, I tell them, this technique is the most important advancement that I've seen in the outcomes of knee replacement since I started my training in 1988. That's all I got. Thank you. Those are all mine too.
Yeah.
Questions?
Yeah, I was practicing general surgery in Upper Michigan around 1984. I suffered the temptation of learning to total knee, the classic one, when I started learning, and then I was inspired by the Holy Spirit to leave that to specialists. I appreciate your talk.
So, from what you said, my understanding is that your goal has changed in what your alignment is, but the actual implants themselves are not different?
Correct. All the implants that are presently on the market have been designed with mechanical alignment. as the goal. Now, almost all the implants have been designed based off thousands or tens of thousands of CT scans and MRI scans, trying to find the population averages within certain sizes. So one of the challenges there is between cultures, knees differ a little bit. So the Asian culture tends to have smaller knees, they tend to have a little bit different alignment. But all the knee replacements are designed and manufactured for mechanical alignment. The good news is when we put these on anatomically, they actually work just fine and work better than the mechanically aligned knees. There will probably be an opportunity in the future when some of these things get through the FDA to perhaps redesign some of the knees more in line with our anatomic alignment. And actually probably more importantly, to allow us to develop instruments to do it more efficiently. So presently we use the standard instruments and we just alter them the way we do things. But there will be some opportunity to make that a little bit more efficient.
So are you using this technique with all your patients, or are there some that still fall back?
There are a couple of exceptions. If anybody has what we call an extra-articular deformity, we can't use this. And the best example, I've had a couple, is a previous femur fracture. So actually I've done a couple of patients that have had previous femur fracture, but if it's anatomically or perfectly aligned, you can do it. But if that, a couple of them had femur fractures treated decades ago with traction, and that limb was shortened and the fracture healed, but it was rotated. So in that instance, you don't want to use this technique, because if you align it anatomically to the knee parts, it may be malaligned to the patient's limb, because it's not the natural alignment they were born with. Other than that, except for some real extreme deformities, I've done it on everybody. So there are probably 98% of the population you can do this on.
Do any of the other surgeons here do this? Or are you the only one doing it?
Yeah, good question. I get patients ask that. In the U.S., Dr. Howell, the gentleman in California, I've asked him for years how many people are doing it. And we don't know for sure. We know some guys that are doing it. We guess in the country there are probably 20. In the Midwest, there are 2. One of my partners, Dr. Wright, I taught how to do it a year ago, so Dr. Stephen Wright does it as well. There's a gentleman in St. Louis that I think is doing a variation of it. Dr. Pagnano at the Mayo Clinic in Minnesota is doing it. There's a gentleman in Philadelphia, a guy in Houston, and I know a guy in Salt Lake. And there's some other guys that do variations of it, but it's not many. I mean, it's a small fraction of the patient or the surgeons that do replacements.
Is Dr. Wright getting the same outcome as you?
Pardon?
Is
Yeah. I ask him that frequently because I feel responsible because he asked and I taught him. But I ask him and he'd say the same thing that I'm saying. Basically, if I had my knee done, this is how I do it. Now, there are a lot of surgeons, because what I talked about, making those different cuts, it really violates or contradicts what we were taught and how to do it. So that's a big leap to take, and a lot of surgeons just aren't willing to do that, particularly if they're comfortable with how they do it, they've done it for a long time. And some just aren't willing to take that leap. Some people aren't willing to go through the learning curve it takes to do it.
Implications for other joints?
Well, with regard to the mechanical alignment, we know the traditional alignment that there's no necessarily harmful effects on the other joints. Nothing been shown harmful with anatomically aligning the knees, and in fact, we think it's probably beneficial if we get that knee more anatomically aligned. Anecdotally, what we see a lot is a lot of these patients with a bad limp or a bad deformity of the knee, they'll have contralateral knee pain or hip pain or back pain that frequently will get better once we normalize their gait. So usually effects on other joints is beneficial.
What's the total recovery compared to your old lady?
Sorry.
Total recovery?
When a patient asks how long does it take to recover, I say, what are you recovering to do? So, like a lady yesterday, she wants the garden. So I tell her she could probably safely kneel in 10 weeks or something like that. I used to tell patients, I'll give you another example with regard to recovery. Because with traditional alignment, patients have a lot of pain, they have a lot of swelling, they're a little unsteady with their gait. I used to require patients to stay on a walker for a month, and then I'd usually have them stay on a cane until they no longer limp after that, which is usually another month. But when I started doing this, and in fact, for better or worse, when I first started doing it, I didn't tell patients I was doing anything different. And when I started telling patients I was doing something different was when some patients that I had done one knee and then done their other with the old technique, one with the new technique, they were asking what I was doing differently. Then I started telling people. It wasn't like I was doing something radical or hiding something from them, but I just wanted to see if they could tell a difference. But what happened was patients started coming in at a month. A lot of them, the majority had no walker without me telling them to stop it sooner. I would say about 50% come in without a cane in a month, and about 40% come in with a cane, and about 10% still with a walker. And some use the walker because they weren't told to change anything else. Some of them are just carrying it in. I should say, how's my satisfaction rate? Well, I've been tracking studies on all these people for 2.5 years. I never used to do this, but I felt I needed to follow these patients more closely. So I got to update my numbers. But I truly think my satisfaction rate is higher. Is it 100%? No. It's surgery. Patients can have complications. So I'm guessing it's above 95%. And I'll be able to tell you after I tabulate those studies. The other recovery, you used to tell patients, a lot of them, if you had a standing job, you better count on 3 months. Anymore, it's closer probably to 6 or 8 weeks for some people. I used to tell people golf at 3 months. Some of them are doing it 6 weeks or 8 weeks. So on average, it's definitely a quicker recovery. I know Brian has done some athletic training. When we talk about the ligament, the big thing is the ligament releases. When we're not cutting the ligaments, these people just recover quicker. So one common football injury is when somebody gets clipped, they have an MCL injury. So you may have heard about those today, I don't know who talked. But an MCL injury is painful, and it hurts to put weight, and it hurts to bend your knee, and it hurts to walk. But every patient that has a medial release for a varus knee with mechanical alignment, which is about 90 to 95% of knees, has the equivalent of an MCL injury. And what are they doing the next day? They're putting weight on it, and the therapist is moving it, and they're bending it, and the therapist is pushing on it. So the last thing we do for a high school athlete that Friday night had an MCL injury is put them in therapy the next day and have them start cranking on it. So the knee replacements traditionally are painful. And I tell patients this technique, it's not painless, but it's not as painful typically.
What's your dad think of this?
Well, my dad did joint replacements. At the end of it, he did everything when he started back in the 60s. And then when he retired, he did all hips and knees. And he's still pretty sharp. And it makes him curious, not enough to the point that I think he's gone online and looked it up or anything. But he was a mechanical guy. And I had a lady in yesterday whose family wanted to go to Houston for a knee replacement because she has kids there to help and take care of her. And I tell her 80% chance she'll do very well. Very higher chance than that your pain will be better. But unfortunately, if you look at the studies, there's a 20% chance you may ultimately not be completely satisfied with it. So, and I don't try to discourage people if they want the other technique or want another surgeon. The odds are you'll do well, but I think statistically you have a higher chance of doing better with this. Anything else? Well, thanks all for coming.
Just one more question.